actually preemptively thought it prudent to give another antibiotic because patient was already hospitalized and had had one more procedure beforehand. Postoperatively, he was transferred to ICU where he was connected to controlled mode of ventilation and was sedated. Urine output somehow was maintained at least 0.5 ml per kg per hour. Tachycardia and hypotension persisted. He required high titrated doses of noradrenaline over the time, with additional requirement of even IV vasopressin to try and maintain mean arterial pressure above 65, which was falling. In addition to crystalloids and colloids, 1 unit of PRBC was administered because hemoglobin was found to be 7.4. And then we were in the storm of cytokines probably. Lactate levels were increasing on serial ABGs. Hypokalemia, hypomagnesemia was seen. And as you would see on this X-ray, there was a chest radiograph showing massive capillary leak, worsening PF ratio due to acute lung injury which was developing. So the problem which was at hand was decompensated intra-abdominal sepsis with septic shock, with vasoplasia. And fluid responsiveness was found with certain bedside tests, which was associated with capillary leak and acute lung injury. So all this happened right under our nose when the patient was hospitalized. It was picked up later and it was treated also fast. But even at this stage, we were not sure whether this patient will survive. And as you know, the family and the relatives were asking the only question, whether he will make it or not. So what next? He was still not settling down. As you could see, his Apache 2 was 26.5 with predicted mortality above 40%. So are we doing everything possible for this patient? We tried proper antibiotic, fluid resuscitation, we tried source control. Everything was done right according to the Surviving Sepsis campaign. We were not sure whether this patient will survive or not, and we didn't know how to answer the question of the patient's relatives. If we just really want to take a look, fluid resuscitation was done right with hemodynamic support. Cultures were sent, early antibiotic was given, source control was performed. Whatever organ support was needed was started in time. So we were following sepsis bundles to the last nut and bolt. All ICU bundles were being followed. So we face similar situations n number of times, all of us working in the ICUs. We know sepsis is the most expensive healthcare problem, accounting for very large amounts per patient or as a society itself. Data from India is not as much as from US or Europe, but you can see whatever the studies available, the mortality, which is attributable mortality to sepsis, is more than 50% in India. This was one of the first studies, INDICAP study, in which many of us would have participated as well. You will see that the patients who had severe sepsis or septic shock sometime during ICU stay had ICU mortality of 42%. And patients who did not have sepsis, the mortality was as low as 17%. So we know attributable mortality to sepsis is very high. And what were the infective organisms found during these studies? Obviously, gram-negative bacteria findings for morbidity and mortality. ICU mortality nearly 50%. SMR was high. So as compared to predicted mortality, in fact, the mortality was higher. 28-day mortality crossed 50%. Hospital mortality further increased. Median duration of ICU stay was 3 to 11 days, and median duration of hospital stay was 8 to 26 days. So it tells us how severe is this problem at hand when we are dealing with sepsis. One more study in which again our ICU had participated, it was led by Bala Venkatesh from Australia under the George Institute, in which 686 patients in 35 ICUs were enrolled. The most common primary diagnosis was CKD in patients who were in sepsis. Common morbidities we all know. Mechanical ventilation was required in 41%, RRT was required in 13%, and ECMO was required in less than 1%. But it denotes that there is very high sepsis burden in Indian ICUs, with more than 50% of patients meeting sepsis criteria. There was poor agreement found between sepsis 2 and sepsis 3 definitions. And as you know, now we go by sepsis 3 definitions. Most common sites of infections were pulmonary. Secondly, abdominal. Most common invading organism was obviously bacterial. Pathogen profile, as you can see over here. So as you know that for a long time, we know the terminologies of sepsis, but there were no concurrences. And all of you have read how the definition of sepsis has evolved from 1992 to 1922. So almost 30 years now we are into trying to understand sepsis. So sepsis 3 definitions recommend using change in total SOFA score of 2 or more points from the baseline score to represent organ dysfunction. So we have removed the concept of SIRS from the definition. SIRS was systemic inflammatory response syndrome. So in current definition, we have sepsis, septic shock, and multi-organ dysfunction syndrome. Sepsis based on SOFA criteria. Septic shock is sepsis with persistent or refractory hypotension or tissue hypoperfusion despite adequate fluid resuscitation. And multi-organ dysfunction syndrome means the presence of organ dysfunction in an acutely ill patient such that homeostasis cannot be maintained without intervention for organ function. But what I like most is understanding that sepsis does not depend only on the invading organism or the insult. It may be sometimes non-infective as well, but it depends on how the host reacts to sepsis or the insult. So in the definition now it has been included that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So what is this dysregulated immune system? Insult could be bacterial endotoxin or it could be viral. We saw sepsis even in COVID for that matter. Or we know that we can observe sepsis in absolutely non-infective pathologies like acute pancreatitis. So in this, the insult actually causes widespread leukocyte activation and massive cytokine release, leading basically to vasodilatation and increased capillary permeability, leading to hemodynamic collapse, which leads to ARDS, shock, ARF, DIC, and coagulopathy. But then what happens during this immune responses? There is innate immunity and adaptive immunity. So when there is initial homeostasis getting disturbed because of an insult, both the immune responses start occurring. And if they can reinstate the homeostasis, there is recovery, say by the end of first week. But the immune response, if it is extremely fulminant, then there can be early deaths due to overwhelming inflammation. And I can see so many patients come in my memory whom we lost in first 3 days or 4 days also with fulminant sepsis. But adaptive immunity can lead to immunosuppression. And if the immunosuppression goes into further immunoparalysis, then there can be late deaths due to persistent immunosuppression. The intensity of response depends on various factors: pathogen load or virulence, patient's comorbidities, and host genetic factors. What is the most important thing that we must remember is basically in medicine, there are window periods. We know for heart, time is muscle if we thrombolize in time or revascularize in time. Same is true for ischemic stroke, time is brain. In trauma, there is golden hour of trauma resuscitation. And similarly for sepsis, there is a window period for reversibility in sepsis. In this, we have to understand that sepsis is not merely an infection. The culprit here is overreaction of our defense system and not the invader alone. So immunity is a black box. We don't understand how a particular person is going to behave or respond, whether he will recover or go into sepsis. All the patients are not the same. It varies in different patients. I have already elaborated various steps of development of sepsis. So from insult phase to molecular activation phase to system dysfunction phase to irreversible organ dysfunction phase. So where should we act? So we have to pick up and act at the molecular activation phase before it is progressing or in early system dysfunction phase. For that, we of course need biomarkers, but today we are not going to go into biomarkers because we don't have time. But clinically also, we can pick up these phases earlier, and then we can use certain markers to pick up the massive cytokine production. So there are so many of interleukins which have been studied, but some of the prominent ones which we know are interleukin 1, 2, and 10, tumor necrotic factors or platelet activation factors. It was very nice to paint a picture of pro-inflammatory mediators and anti-inflammatory mediators, or SIRS and CARs, where compensatory anti-inflammatory response starts. But it doesn't happen so systematically or in disciplined manner, one after another, but it is all mixed up, pro and anti-inflammatory mediators. So there have been trials of trying various methods based on these markers or the inflammatory molecules which have been studied. So there was anti-TNF developed or anti-inflammatory interleukin 2 or interleukin 1 or anti-LPS, that also was studied. But this is like a story of an elephant and 7 blind men, because when there are so many inflammatory molecules which are being produced just by, for example, use of tocilizumab, just one particular molecular antibody, monoclonal antibody against a particular marker or interleukin will, maybe that particular level will go down, but it is not going to reverse the damage caused by other intermediate molecules. And then this exaggerated response in sepsis will have to be controlled in some manner or the other to avoid the early or delayed mortality. Okay, this is a study which was published in 2007, where there was a simple study to monitor IL-6 and IL-10 levels, pro and anti, in community-acquired pneumonia, which showed that high IL-6 and high IL-10 was mostly correlated with high mortality. So we'll talk about that later. But coming back to bedside assessment, because that is what we do day in and day out, right from starting from casualty or the wards to ICU. So there are very, very simple bedside parameters which all of us can monitor, like high heart rate, fever, shivering, or patient feeling very cold, confusion or disorientation, shortness of breath, extreme pain or discomfort. Peripheries can be warm with bounding pulsations with low diastolic pressure or very wide pulse pressure. Or if it has been progressing further, it could be clammy or sweaty skin. So we always have to touch the feet of the patient and always judge what is the difference between core and peripheral temperature difference. So all these clinical pictures together will ultimately prompt us to consider a high probability of patient having sepsis. And the current development of SOFA score, which is sequential organ failure assessment score. You can see here, it has been made much easier than Apache 2, and respiratory, cardiovascular, liver, renal, coagulation system, and neurologic system. These are the five systems, six systems, which have been taken into consideration with minimum points from 0 to 4. So patient who is having very severe sepsis, maximum score could be like 24. But again, this requires some ICU, what I would say, monitoring and the lab parameters. So quick SOFA score was developed where it is only clinical, which takes into account respiratory rate of more than 22 in an adult, change in mental state, acute change, and systemic blood pressure less than, systolic blood pressure less than 100. By definition, it is actually less than 90. So if there is a change of 0 or 1 point in a patient who has been suspected having sepsis, the risk is relatively less. But if there is a rise by 2 or 3 points, then the risk of poor outcome is quite high. You can see here various studies show us the correlation of SOFA score to outcomes. So this is the range of SOFA score you can see in this table, which correlates with various percentages of mortality. So some predictability can be helpful for us to decide the speed of our intervention. Because as they say, when you are skating on the thin ice, safety is in the speed. You can see here the score trend. If it is increasing in first 48 hours, the mortality is likely to be more than 50%. So we all have to be continuously monitoring the patients and very careful to the changes. So in a nutshell, sepsis is a complex and challenging syndrome. Numerous definitions and developments of new evidence makes diagnosis constantly changing, and we have to be alert on our toes. There is no single specific test to diagnose sepsis, though lactate may help us in objectively diagnosing sepsis and hypoperfusion. In critically ill patients, prior use of antibiotics makes cultures negative. So we have to be very, very stringent about sending blood cultures and utilization of antibiotics. You could find this type of various protocols which you can actually stick in your ICUs or wards so that even the new joinees or even the nurses could follow similar protocols to improve the overall outcome. And then we come back to our window period again after understanding all these developments at molecular level and assessment at the clinical level. So 1 hour bundle now includes measure the lactate level as the first line of management or diagnostics. Obtain blood cultures before administering antibiotics. At least 2 sets, aerobic and anaerobic. Administer broad spectrum antibiotic after that, which again should be within 1 hour or at least within first 3 hours. Begin a rapid administration of fluids, 30 ml per kg of crystalloids for hypotension or lactate level of more than 4 millimoles per liter. And then, despite that, if the patient is not improving, apply vasopressors if hypotension is not improving to bring mean arterial pressure at least to 65. This is one of the papers which still stands the test of time. It was published in 2006 by Kumar et al. From Canada, and which studied retrospectively the time of antibiotic administration and the survival or the mortality. Time of antibiotic to hypotension, incidence of hypotension was studied. And survival was 82% if the effective antimicrobials were administered within 30 minutes of initial evidence of hypotension. And as the time started getting delayed, the mortality started increasing. So survival started decreasing as the cumulative effective antimicrobial initiation time went on getting delayed. So we should never forget this for our patients. Retrospective studies further came up which reiterated the same findings that hourly delays in antibiotic administration were associated with increased odds ratio of hospital mortality, even among the patients who received antibiotics within 6 hours. So we have to administer them expeditiously. This graph is quite self-explanatory. And then we come to fluid responsiveness, which is one of the forte of intensivists who are working by bedside of the patient. So what is the definition of fluid responsiveness? It is the ability of left ventricle to increase its stroke volume in response to fluid administration. As we know, the specificity of the process of sepsis is vasodilatation. The hallmark is vasodilatation. So there is reduced afterload. So there is reduced resistance. And in fact, the heart is pumping very well, or it is hyperdynamic circulation. In fact, the cardiac output can even double in sepsis syndrome. And in this, it is extremely important to decide what is the fluid requirement of the patient. We cannot say that we have given 1 liter of fluid and still patient has not improved, so we have started vasoactive agent. No, the requirement of the patient could be 2 liters, 3 liters, 4 liters. And that is what fluid responsiveness tasted by the bedside is going to help us decide without patient going into fluid overload. Fluid management is a walk on the tightrope, because if there is increased cumulative balance on the 4th day of ICU stay of ICU patient, it is correlated with worse outcomes. So we have got a very short window period where we have to resuscitate the patient. At the same time, we should not allow patient to go into too much of a positive balance. Or once the patient stabilizes, then we have to start removing the fluid also from the body of the patient. So all this has to continuously be rushing through the minds of an intensivist who is managing patient bedside. So fluid administration is the first step in the management of patient with acute circulatory failure for increasing cardiac output and oxygen delivery. It used to be said till some time back that when in doubt, give fluid. But since we know that cumulative balance in long term is not going to be very beneficial. So whatever fluid bolus can increase either stroke volume or cardiac output by 10 to 15% after fluid bolus is called as, the population of the patient is called as fluid responders. So it is obvious that when we are giving fluid, only pulse rate or respiratory rate or blood pressure, invasive or non-invasive, cannot be telling us exactly about fluid responsiveness. So we have to have certain methods to monitor stroke volume or cardiac output bedside. And what are those? That is also extremely important. In modern day intensive care, all of you have to learn how to monitor fluid responsiveness, to answer the questions when to give fluid, how much to give, and how long we should give. Did you know that only 50% of hemodynamically unstable patients are fluid responsive? This was mentioned in a study, observational study. And it was also noted that physical exam alone is a poor predictor of fluid responsiveness. So with all this, we come to the passive leg raising test. Maybe after initial bolus of 500 or 1 liter, when we are trying to answer more precisely, we should go for passive leg raising test, which is going to tell us about whether patient is going to be responding or not. The methods of assessing static indices and dynamic indices we will have to learn. The non-invasive or minimally invasive methods now are the mainstay of monitoring in the ICU. And I'm really happy that one of our DM students has taken up this topic to study the carotid flow time, which is going to study the ratio of systole time to cycle time by doing ultrasonic assessment, methods by which we can check all these things. Basically, sometimes it is only in ventilated patient, which is pulse pressure variation. But we cannot do that only in ventilated patients. What about non-ventilated patients? So we have to establish these methods in them. EtCO2 also can guide us on that. Increase in EtCO2 by more than 5% after PLR indicates fluid responsiveness with 91% of sensitivity. IVC diameter, 12% of delta IVC diameter after PLR, 12% increase. It helps us to identify patients who will respond to fluid. And the pulse pressure in also, the change, delta change more than, see, patients who are having pulse pressure more than 12% or 13% variation, if it reduces after PLR, it correlates with fluid responsiveness. So there are various guidelines, various studies which have told us that only CVP is of no use. Even though this observational study tells us that CVP is still the most commonly used variable, and even if it is of no use because it's a pressure monitor and static monitor. So all of us have to learn PLR. I would spend a minute on explaining the PLR, not a drop of fluid, but we have to follow these 5 steps of the rule. When the patient initially is in semi-recumbent position, without touching the patient, just by movement of the bed, we should use the bed adjustment and avoid touching the patient to make his head low and raise the leg end of the patient. Assess PLR effects by directly measuring cardiac output, not with blood pressure alone. Reassess cardiac output in semi-recumbent position again, and it should return back to baseline. That means that this patient is responder. Use real-time measurement is more important, and then we start going towards volume expansion. Move the bed and not the patient. That is what is indicated in the study. Administration of 30 ml per kilogram crystalloid within first 3 hours minimum. So that is the fluid resuscitation, monitoring all the parameters plus cardiac output, as I mentioned. ACVO2 has lost its fervor after goal-directed therapy has been disproved for positive outcomes in patients. Use of balanced crystalloids while resuscitation have shown the potency or probability towards improvement and also reduction in requirement of RRT. And so you can check the chloride level of the patient, sodium level of the patient, and then decide which fluid to use. But balanced crystalloids may have little edge over use of normal types of the shocks. So in all 3 types of shocks, all patients show norepinephrine to be better. Patients, it was studied in adult patients, of course, higher rates of mortality and arrhythmia with dopamine than with norepinephrine also proven, no doubt about it. There are studies which compare and so also some newer vasopressors are being studied, like angiotensin 2, which is a non-catecholamine vasopressor that preferentially causes vasoconstriction. It is shown to increase blood pressure in vasodilatation. Detail right from 1987 to 2016. Now we have reached to a current acceptance of consider giving hydrocortisone in septic shock after adequate environment of
sorry ma'am,
sorry
your network is little bit slow ma'am. It's
okay.
problem in the voice quality.
All right. Okay, I'll just change that. Is it better?
Yes, yes. Yes, ma'am.
Is it better now?
Yeah, seems to.
Yeah.
Yeah.
All right. Okay, I changed the network. Okay, so I was talking about steroids, and everyone knows that the evidence is little weak, but we are considering use of corticosteroids in septic shock after adequate fluid resuscitation and use of vasopressors in patients who are not responding also. So it showed that the number of days of vasopressors could be reduced by use of hydrocortisone. Showed that the time to resolution of infusion of hydrocortisone did not help to lower observed in these patients with reduced ICU stay. Source control is beyond emphasis. It is so much important that source control intervention be implemented as soon as medically and logistically practical after the diagnosis is made. This question always comes to intense. For example, our patient initially, which I had shown, initial optimization as much is unfit to undergo surgery, the patient who is septic and the source needs to be removed. So prompt removal of intravascular access devices that are possible source of secondary sepsis, it is again extremely important. Then there are certain parameters which are shown in surviving sepsis guideline, which become a part of ICU bundle. These are extremely important because they contribute to overall good outcome in patients who are septic in ICU. So mechanical ventilation is based on ERDSNet protocols, which promotes protective lung ventilation, and we cannot go into all those details right now. VT thrombo means venous thromboembolism prophylaxis patients where there is absolute consider non-pharmacological prophylaxis. Sepsis is even double the risk. So sometimes we may have to use even both the parameters or both the methods for venous thromboembolism prophylaxis. Nutrition cannot be overemphasized because nutrition is so important to protect the gut-related immunity. So trophic feeds have to be started as early as possible, and translocation of bacteria can be prevented. Helps to reduce the carry phase. Glucose control is very important. Tight glucose control, so-called tight glucose control, is not recommended. Control goes haywire for various reasons. We have seen the cytokine storm itself as a cause, then various drugs, the stress response, and steroids. Sedation and analgesia as appropriate. I will not spend much time on that. Important right from the beginning. So elevation of the head end, we know all that. And agreement on treatment. See, sepsis is one of the multidisciplinary management, and then we really have to be with all the teams. So goals should be common with everyone, and the ICU team also has to be together on whatever we are doing in sepsis is very important. Use of blood products, we know all these. So I will not spend too much of time, but 7 grams is the threshold. Prophylactic platelet transfusions, when counts are less than 10,000 in absence of apparent bleeding, And when counts as less than 20,000, if the patient has required, then more than 50,000 is required. Recommendations are weak, but that is what is being followed in most of the ICUs. Glucose control, we have talked about it.
Madam, we have the same issue again. Madam, we have the same issue again. Madam, audio is again breaking up now.
Okay, I have
some network issue from your side, ma'am.
Yeah. Okay. I hope it is better.
Little better, but not. Still, ma'am, still audible.
Okay. Is that better?
Yeah.
No. No?
Yes, ma'am. It's a little better.
Yeah. Is it better? Little better?
Yeah, yeah.
Yeah. Okay. For deep venous thrombosis, and CVC is a very high extremity on ICU admission had increased and early ambulation. So even ventilated patient, as you can see here, can be mobilized. And these are the important issues which we should not forget. So same question we had to answer again, whether requirements were increasing, fluid responsiveness was persistent, which was getting corrected. So due underlying evident cytokine storm, and in this, 2 cytosol devices were used for this particular patient as adjuvant therapy. Each along with standard, but this prompts us that what are the new frontiers and what is the window of opportunity which we should learn and explore, and what is the direction sepsis is going further to. There is something called as code sepsis, like we have code blue or stroke code where sepsis can be recognized early and the objectives can be met to ensure rapid identification of sepsis or septic shock, to facilitate early initiation of clinical interventions. Okay. Okay, I'll just go ahead, last few slides. So code sepsis helps us for early and rapid treatment of these patients with significant increase in So applying code actually helps junior doctors or untrained doctors also to pick up sepsis very early. This helps to improve antibiotic use, time to antibiotic, early shifting to ICU, rapid fluid resuscitation. So it helps for overall outcome. So we should start early to recognize cytokine storm and probably early cytokine removal in selected patients. We have done a study, initial study on hours after completing survival sepsis goals. This could give a better survival in patients. It was shown that there was improved time to reduction in vasopressors, improved time for reaching mean arterial pressures. Therapy significantly also was observed in the drop from, you can see here the values almost more than 2,500, dropping to significantly low levels. All other parameters also showed significant drop. Anyway, so coming to best practices in sepsis, major lactate levels, obtain blood cultures, administer broad spectrum antibiotic within time, begin rapid administration of fluid 30 ml per kg crystalloid in first 3 hours, apply vasopressors if hypotension persists after fluid resuscitation. And what is most important with all the large number of studies which tell us is recognize sepsis early. 1 hour bundle, which is depicted in this picture, to be followed very meticulously. Source control is very important. Supportive therapy and organ support for patients who don't respond to early therapy. So we have to keep on the support. Immune modulation is still a gray area and experimental area, or you can say research area. So tools such as QSOFA help us. I think this is the hand it over to Dr. Gunadhar. I will stop sharing the screen and hand it over. I'm really sorry for disturbance in between, but I hope you could hear properly.
Yes, sir. So there is a little bit of disturbance, but this is an excellent presentation overall, ma'am.
Yeah.
Really appreciate. So any questions from the students?
There are a lot of nuances from the new Surviving Sepsis campaign, and they've given focus on early resuscitation and bundled approach, from 6 hours to now, from 3 hours to 1 hour. This bundled approach has really revolutionized. And as madam has said rightly, like, we have code blues, we have stroke protocols, stroke, similarly for sepsis also, there should be a code conducted, and early intervention will definitely help us to revive patients. So I have one question, madam. I mean, there is a lot of emphasis on, mean maintenance of mean of 65, but it varies from age. Actually, if you see at elderly age, the mean maybe the normal mean for that particular patient may be 70, 75. But isn't it keeping 65 mean for that patient is hypotension? And are we really sure about the organ perfusion maintained at a mean of 65? There is a lot of debate on that. What is your take on this?
So this is a
And this question is all to the
very important point, point 40 or 150. The drop of 20 or 30 in systolic itself can be a shock state. So similarly, the goal for resuscitation also should be different. But unfortunately, most of the studies have still not shown that the higher goals help.
I think we are not audible.
Overall outcome.
I think.
That is why the sepsis definition 3 has still included 65. You please add. I think it is very important. Abel, I would request. I will stop the video. Perhaps that will help for better.
Yes.
Yeah.
Video, you can stop.
Right. That's good. So I agree with you. I mentioned that systolic blood pressure in an adult or elderly patient who was normally maintaining it like 140 or 150, even drop of 30 mmHg or non-requirement of antihypertensives itself can help us suspect shock in that patient or septic shock. So even though the sepsis guidelines 3 mentions still 65 as the goal, it is little doubtful. But there is no conclusive evidence which will tell us that the higher requirement or higher goals can give us better survival. That is why still there has not been any change.
Right.
I would request both of you also to add to this, or any of the chairpersons to add to this.
Yes. So let's have the opinion of Dr. Hitesh and Dr. Amit.
Yeah. Yes. I think Madam is also aware in sepsis bundle guideline, certain subgroup of the patient who require the little bit higher MAP, such kind of CKD patient we are also seeing, and you are also seeing. A CKD patient requires a little bit more blood pressure. So suppose we are targeting the 65 MAP, he may not not pouring the urine output. So certain subgroup of the patient who are the already hypertensive or CKD, this kind of patient may require a little bit higher MAP, but still the study was not done, and this area require a little bit more study. But yes, we are also seeing such kind of patient who are hypertensive and present with the hypotension. Such kind of patient little bit require the little bit higher MAP, or it may, if we are maintaining the 65 stringently, then urine output may drop, create may go up. So such kind of experience we are facing, but still the study is not suggesting. So it might be required the larger
Right.
of the studies.
And ultimately, rather than only believing in the what I would say end goals, we ultimately have to monitor how the organs are behaving in response to whatever resuscitation we are doing.
Yes, that organ behavior.
And that is why goal-directed therapy went away, because just the absolute numbers don't mean anything in a physiologically disturbed patient.
Absolutely.
Yeah.
So one of the question is from Dr. Sanket. What is the role of vitamin C and the multivitamin therapy in a septic patient?
Right.
So,
high dose vitamin C, there are few studies which have shown this, but I think they have not been able to replicate it. In fact, one of our students had taken this up as a thesis for his DNB also, and it was not proven that it directly helps. But I always insist that we should supplement vitamins in septic patients, no doubt about it, because it is, these are water soluble vitamins, and when the patients are in severely catabolic state where we are not important molecules for basic physiological processes that are happening in the body. So I'm not a proponent of high dose vitamin C in the ICU. Again, I would request all of the panelists to give their opinions.
So Dr. Amit, what is your opinion about it?
Yes, Dr. Gunadhar. Yeah, actually, I was going through these guidelines and I happened to contribute with regards to the, am I audible?
Yeah.
Yes.
Am I audible?
Yes.
Yeah. One of the guidelines, the mentions about use of standard heparin and not so much use of the mechanical compression devices. That is what it was saying. So heparin as such a molecule in sepsis is a little tricky thing. If our assessment is wrong, then the patient can move towards the bleeding tendency. So what is the take-home message? May I ask Prachi madam to throw some
So
light on this?
high dose vitamin C is not really, I'm not a proponent of that actually. But regular physiological doses, we have to supplement.
Yes.
Right. Ma'am, there is another questions like what are the newer inotropes actually you have mentioned? Basically, there is a break in the audio, so most of the delegates they won't able to
Could
hear it.
not hear.
Yeah,
Okay, that was angiotensin 2. So angiotensin 2 is being studied because which is a non-catecholamine type of vasopressor, which has got direct vasoconstrictive action. So the studies are coming up. It is still not being recommended in clinical practice, but the research is going in that direction, like how vasopressin was studied. So vasopressin still has the role as a combination with noradrenaline, but we still do not know what is going to be the role of angiotensin 2.
Okay. Another question by Dr. Kishore. What is the highest MAP recommended if we want to target MAP more than 65?
I think we discussed it already. So there is no number that is recommended, and we have to personalize it bedside based on the response of fall in lactate levels and organ function improvement.
Right. Another question by Dr. Sanket to Dr. Hitesh and Dr. Amit. So role of tests like Sepsis quick panel for early detection of these organisms versus the routine blood culture. So what is your take home on this? Like sepsis multiplex panel.
I still feel routine blood culture is rather more informative.
Yes. So right now, its panel is very good because it has, I think here they are using the PCR panels. So whenever the certain cases, suppose respiratory patients is there, we can get a report in the 24 hours, while the blood culture or ET culture or sputum culture will take 48 hours to 72 hours to 96 hours. So these PCR based technique are certainly very helpful. So suppose we had right now one immunocompromised host, multiple myeloma. We sent the, he's in the right now septic shock. We sent the sputum that it is, we have sent the ET and it's turned to a certain organism positive, so we can get to a proper conclusion of which antibiotic we have to give. So yes, definitely, and this is under evaluation, and many studies are focusing this kind of study. But blood culture is definitely a gold standard. But this PCR techniques means septic, whatever we are telling is respi panels, they are very helpful in such kind of patient.
Can I just add one thing here?
Yeah.
So sepsis quick or whatever it is, whatever the technology,
yes,
it is basically PCR based technology in the
PCR based.
blood. So this is based on artificial intelligence actually, because they may find multiple PCRs positive also.
Yes.
And we know that PCR can come positive even on the dead organism.
Yes.
And then it if it detects multiple PCRs, then by algorithms, they will say which is the most likely organism, not really the live organism. Cultures tell us about the live organism. And as we know that in a septic patient, we have to correlate everything towards the probable focus of infection. So we always discourage pan cultures to be sent, because we send pan cultures and then something is shown in urine culture positive, but whereas patient is actually having focus of infection in the lung, which is not growing anything yet. And you start treating whatever organism is grown, which is from urine. So it is of no use for patient's sake. And in fact, undue utilization of antibiotic can be seen because of this. So whatever newer tests, we will have to compare them with the gold standard tests like blood culture. Unfortunately, we still do not have time to, like even Malditov, it can reduce time by a few hours, but blood culture has to grow, which takes its own sweet time, like minimum 48 hours, I think, even in most modern cultures, most modern methods.
Right.
There are a few questions in the chat box. What is the role of newer molecules like unilastatin? Do you have any experience of positive outcomes after unilastatin? There are a lot of
Ulinastatin, actually, we had participated in a study also at that time. So, as I mentioned, immunomodulation is a very, very attractive proposition for all of us. As we know that immunomodulation or the black box of immunity is ultimately going to alter, because now the definition also has included that dysregulated immunity is the problem in sepsis syndrome. But ulinastatin did not prove in any sort. Only thing which was proven with ulinastatin was early pancreatitis and cardiopulmonary bypass.
One question by Rumna Sultana. I think I'll pass this question to Dr. Amit. When should you use dobutamine in the management of septic shock?
Dobutamine, I think, has not much of a role in the septic shock patient. But yes, if the septic shock patient has a cardiac background, probably patient with LVF, and by fluid resuscitation, you have gone through the protocolized approach. That is, you send the cultures, you've done the fluid resuscitation and started the inotropes, probably vasopressin first, followed by NORAD, not getting an improvement in the end organ perfusion, then we can think of adding dobutamine, and that too in very low doses. I personally feel it is more arrhythmogenic and should be cautiously used. But for a cardiac patient, yes, definitely it has a role.
Any role of dopamine in current scenario?
Dopamine, I
really.
think, has no.
Yeah, go ahead.
Yeah, madam.
Please go ahead.
Dopamine, I think, has no role at present. Because we have better agents and more approved ones, noradrenaline, and in fact adrenaline has a role, but dopamine does not.
The only indication may be probably patient with the bradycardia and having sepsis. Probably these are the only indications for dopamine. And dobutamine, definitely, if the patient has documented myocardial dysfunction, low ejection fraction, and patient is in sepsis, he is hydrated well, probably dobutamine can be used in that situation. So there
we have to remember that dobutamine actually has a peripherally vasodilatory action.
Yes.
So it is extreme. I mean, it may so happen that by addition of dobutamine, actually blood pressure may drop.
Yes.
So we have to choose very, very rightly, and very small percentage of patients maybe. In goal-directed therapy paper by Rivers, they had used it in certain patients in whom they tried to bring down the blood pressure by addition of dobutamine, patients who were on going hyper. So dobutamine is very, very disputed.
So if at all dobutamine has to be, it has to be used along with the vasopressor like noradrenaline.
Correct.
Probably. Then only we will be able to prevent vasodilatation.
Yeah.
So there is one more question. What is the role of plasmapheresis in sepsis? Dr. Hitesh, would you like to answer?
So plasmapheresis is right now not recommended in the sepsis. As already, I think Meadow have also mentioned, only blood product HB target is 7 to 8, but plasmapheresis doesn't having a role in the sepsis. It is having a role in autoimmune diseases.
True. Yeah. Absolutely right. See, this is again a very attractive proposition to try and remove all the toxins, all the cytokines, all the interleukins, etc. But plasmapheresis removes very large molecules also, and it can remove proteins basically. So what filter you use is extremely important with the idea of what type of molecule you need to remove. So right at the beginning, I showed that figure where pro and anti-inflammatory peaks are seen. So high volume hemodiafiltration was one of the first methods which was studied for removal of various types of cytokines, but it showed no difference in outcomes. Similarly, plasmapheresis, so as Dr. Hitesh mentioned rightly, has no role in sepsis.
So, madam, this question I'd like to pass to you because I think you have done a lot of work on this. So, role of CRRT and cytosol filter, particularly in cytokines term, which phase and when to use, how early?
Right. So that paper which I showed you, which we had published recently in the World Journal, it was from 3 or 4 centers in India. And we used this filter in a properly chosen set of patients in proper time window. So when patient is still in the reversible window, patient has evidence of cytokine storm clinically, plus we are actually following IL-6 levels in most of the patients, and the patient has not responded to meticulously followed surviving sepsis guideline bundles. So then something additional needs to be done with the probable or predicted mortality of like 40–50%, then we can give a benefit of this additional immunomodulatory therapy in this subgroup of patients. We have used it in patients with non-bacterial sepsis also, like acute severe pancreatitis with organ involvement impending and with successful outcomes, or sepsis because of vasotoxic, vascular toxic snake bite, for that matter.
Did you monitor any biomarkers for that, madam? Did you monitor any inflammatory
So sepsis of
markers?
any cause. Yeah, for every patient. Yeah, we have monitored in the patients whom we presented in the paper. We had used IL-6 and IL-10. IL-6 as a pro-inflammatory marker, IL-10 as anti-inflammatory before and after the therapies, and the requirement of ionotos before and after, changes in organ failure scores like Apache score before and after, and we had calculated predicted mortality before and after.
And,
Just I had one query, madam. IL-6 is a very short acting, okay? So value will change rapidly. So support you are using any long acting markers. So CRP, ferritin, such kind of
CRP also. CRP
Yes.
also. In these patients who were studied, we had used CRP also. So ferritin was not used in sepsis. Ferritin we had used a lot in patients with HLH, because we had used this type of therapy even in dengue-induced massive HLH, where ferritin levels were like 25,000 and 30,000, that high, or liver enzymes were in thousands. So in these patients, CRP, IL-6 also was very high. And we have got some success stories with utilization of HLH in HLH syndrome of dengue also.
So you are getting a good result with the dengue HLH.
We are getting. Just recently, we had one patient who came with toxic, absolutely toxic, including encephalopathy, platelets 10,000, renal failure already set in, etc., etc. He improved in first 5 or 6 days, and then he suddenly developed changes in ECG and arrhythmias. So probably myocarditis set in at that time, but otherwise he was improving. And we have at least 5 cases of HLH dengue with thousands ferritin in thousands values, who improved and went home.
Many centers actually they measure this endotoxin assay also. So before they put the patient on filters, and they measure the level after putting the filters, and there is a significant dramatic decrease on the endotoxin level. What they documented.
Yeah.
So
there were studies, but actually that LPS now has gone off because large randomized trials showed no benefit of removal only of LPS or endotoxin level.
Right. So which is a better filter, ma'am, Auxaris or Cytosorb? It is asked by Dr. Harsha.
It is not only Cytosorb, there are multiple filters now available. Cytosorb, of course, has got maximum evidence. It is recognized in or allowed to use clinically in Europe also and US also. That is why there are lots of evidences coming up, or lots of cases or case reports and studies are coming up. Other filters have not yet been proven or documented so well, but there are multiple filters now. I have maximum experience of using Cytosorb and Hemophil.
Okay. And one question is from my side, ma'am. Any role of IVIG in case of septic shock?
No, again, like plasmapheresis, IVIG also has not shown or proven benefit in septicemic shock. If you have experience or any data you can show, please.
No, ma'am.
You can share.
And the another question is the role of microcirculation monitoring, in particularly in septic shock patient. Dr.
Yes, Dr. Hitesh.
Dr. Hitesh, you want to comment?
Role of the microcirculation. So I think I'm not getting a question. Means role of microcirculation means
Are you monitoring microcirculation routinely, like,
To
capillary,
achieve goals,
to achieve your goals, like
perfusion
capillary output
goals.
time or any other monitor, which
no
is
we are not using the microcirculations.
plethysmographic principles or, circulation of the tongue or
Like
people. There are
gastric
several monitors.
tonometry or
Tonometry.
percutaneous oxygen saturation monitoring,
No
No.
non-infrared spectrometry and all.
no.
No, I think they are still quite experimental methods.
They are
Yes,
still
And
in
in
evaluation.
addition to the standard treatment, it is still being studied. But for bedside utilization, I don't think there is any much role.
Yes.
But it is still in the evaluation phase.
Yes.
What are the challenges in resource limited setups, like managing patients with the sepsis and septic shock? Can I ask this question to Dr. Amit? Dr. Amit, would you like to highlight the important points
Dr.
in
Akhilesh.
actually in resource limited setups?
The place where I work is something like that, resource limited, and advances in medicine happen to reach here a little late. But whatever the basic things are there, we intensivists here are following that. Suppose some guidelines are coming with respect to sepsis management, they are easily incorporated if they are more of clinical based, which means that, for example, resuscitation guidelines are there, then antimicrobials which are to be used, particularly if you are suspecting gram negative sepsis or gram positive sepsis. Those things are done very well. If we happen to shift a septic patient from one center to another, then it is a really difficult task over here. So in that case, what I have found useful is something like telemedicine.
Yes.
We do consult uh, consultants at cities and more better centers, take their help, and I feel that is a better way of managing patients at resource limited scenarios. Blood bank support that we are getting very well here, and as far as maintaining taking aseptic precautions and doing the procedures in an asepsis environment, source control, as what madam has emphasized, that also is being practiced. So we are doing the basic things, but many more things need to be done.
Yes.
I think the major challenge in resource limited setups is diagnostics. And one more challenge at resource limited thing is basically using your clinical judgment very well.
Yes.
So training your manpower and junior doctors to have high suspicion or pick up early unstable patient and stay bedside and see the responses. See, ultimately, what is a fluid challenge? If, suppose you don't have cardiac output monitor, you can be absolutely with open eyes, see the clinical improvement. So that training of junior manpower is one of the most important things. Sometimes the experienced nurses can tell us better than the doctors. So we have to develop these resources also.
Yes, madam, I agree with this. And in fact, at resource limited situation, your clinical diagnosis and clinical steps that
Very
you take,
important.
that only
Yeah.
help you.
Yeah, and we don't have to use fancy antibiotics here in resource limited setups.
Yes, madam. Very true.
Can,
Very true, madam.
ma'am, can I
Yes.
ask one more question? It is related to the dengue. Suppose the dengue patient having a bleeding, platelet count is less than 20,000 and APT is also 2 times, 3 times most. Capillary leak is there. So will you give the only platelet or you can supplement the FFP or cryo?
We have to check fibrinogen level.
Yes, fibrinogen. Okay.
Yeah. So if fibrinogen level is low, then we can supplement with it. But any dengue patient who is severe, increasing severity or dropping in 2 cell lines, we must check ferritin, LDH, triglyceride levels, and suspect HLH in these patients early. before they go into multi-organ failure. It's a very small percentage of overall dengue patients, but when HLH sets in, then you have it. Then it's a very, very difficult thing, you know.
Right. So in the continuation of this question, ma'am, regarding antibiotic resistance. So one question is like, when you are using a lot of multiple antibiotics, nowadays we know that most of the bacteria are resistant to meropenem. Okay? So is it necessary to consider ceftazidime avibactam as the first line of treatment till we get the culture report?
No. I wouldn't recommend that, because we don't want that molecule to go in the same way as penems went. So we should not use empirically
Absolutely.
the antibiotic, which can be our, the last resort or the final bullet. So I don't recommend that.
Antibiotic should be guided by the antibiogram of the hospital. What is the most prevalent flora in our hospital? And
Yeah, but
we also should take into consideration the resistance pattern, whether you have more of OPSA, more of NDM or ESBLs. That should guide us as initial empirical antibiotics. And now most of the centers have developed resistance to meropenem. More than 50% of the times you will see the organisms are resistant to meropenem. So in that situation, combination of antibiotics can be more prudent, like monotherapy probably, and monotherapy with colistin can also be useful. These ceftazidime avibactam, this should be reserved drugs. Actually, it should not be used empirically unless we have our own available drugs. I think we should reserve it for those patients who are extremely sick and indicated and justified. Like if the patient has NDM, we should use ceftazidime avibactam with aztreonam. If it is just OXA 48, ceftazidime.
Yes, OXA 48 is must before using. Yes.
So that's why we should
document
guide our
the
therapy with resistance pattern as well.
Document the sensitivity pattern also of the ceftazidime avibactam, and then we have to ideally justify the use actually.
Oh yes.
So just using for carbapenem resistant actually also is not going to help much.
Yeah, but at most of the places, Carba-R test is not going to be available. We have to remember that also. And there are certain caveats. While I have always noticed it, when we talk about antibiogram, patients who have come from other ICUs to us as a tertiary ICU, their antibiogram is going to be from the place where they have come from and not ours where they have reached. So sometimes there are dilemmas we face. That is why we probably cannot generalize. We cannot have generalized rules. But most of the times we have to follow what Dr. Akhilesh has said. That is true.
And then we should categorize the patients according to the severity of the disease. Class 1 community, class 2 referred from other hospital but stable. Class 3, a patient is transferred from other hospital but unstable state and has not received broad spectrum antibiotic. And class 4 is a group of patient who has already received broad spectrum antibiotics, unstable hemodynamics, and these are the patients where we can, try. I mean, even ceftazidime avibactam may be used empirically if a patient has already received meropenem in that setup or something like that.
I agree. I agree with you. Yeah.
Any other questions?
Right, so good discussion.
So,
no, I don't think we have
any final points or suggestions or word of wisdom to the audience from each one of you, starting from Madam and then Dr. Hitesh and Dr. Amit can also give the few words of wisdom as far as resuscitation of septic patient is concerned.
Good. So if you are asking about resuscitation, that is one of my most favorite topics. And I have been always telling my juniors that you cannot order a fluid challenge and go for tea. You have to stand by the bedside of the patient, because sepsis is ever changing. Every few minutes, the patient is changing his status and you have to change your decisions. You can say, sister, 500 ml de do, main aata hu. So that is not the way sepsis is managed. You have to stand by the bedside of the patient and keep observing, utilize your tools properly to judge the response, whether the patient is improving or deteriorating.
Absolutely right.
Right, absolutely. So the clinical sense is very important actually in every aspect. upset.
We are
Yes.
going more towards the gadget. We are all
Yes.
becoming gadget freak
Yes.
clinicians, but we
Yes.
should
I
not forget
Yeah,
the
I
basics.
always tell them touch the feet of the patient.
Yes.
Patient
Yes, it
will
is
bless
good.
you. Why? Because core peripheral temperature difference is one of the most important things which will tell us whether our resuscitation is successful or not.
Yes, and absolutely, they should able to understand between the warm shock versus cold shock.
Yes,
Yes.
true.
Dr. Hitesh.
From your side,
Ma'am have already spoken extremely good words about the sepsis. But yes, sepsis we should treat in it's 1 hour is our golden hours. We should treat the sepsis. We have to cultures and we have to give the proper antibiotics.
Probably we
source-
should also have, like we have code blue, we should
Yes,
also
we
have
should,
a
yes.
sepsis
That is a
blue
Code
good concept.
sepsis.
Yes,
Code
code
sepsis
sepsis
Yeah.
is
code.
important
Actually, in our
concept.
hospital, we are working on that, and hopefully we should be able to implement it soon.
No, it is very good concept. Really.
Yeah.
Yeah, it's a good, definitely a good
Dr.
concept.
Amit. Yeah.
Yeah,
Can you-
actually, I just want to add to tell the juniors that in my experience, the elderly patients, elderly adults, they behave in a very weird fashion during
Yes.
this resuscitation phase. That's what I have seen. So, as Madam said, we have to be doubly cautious when we are dealing with this patient, and they already have less organ reserve, organ function reserves. So they may decompensate during the resuscitation phase. So it has to be like properly attended and done.
right.
Yeah.
So it's a wonderful program. So I would like to thank all the panelists, Prachi Madam, for such a lovely interaction and make this session very interesting. And hopefully, ma'am, so like to see you more and more in our programs. And really,
Yes.
thanks from our side to all the panelists and Madam also.
Thank you. Thank you. I'm really
Thank you.
impressed the zeal with which you are carrying on with this program. And I can
Yes,
see
yes.
the students are getting benefited.
Yes, ma'am. Yes, ma'am. Thank you.
Thank you. I'm
Thank you,
sure
sir.
from
Thank you,
our
Prachi
unit,
madam.
more and more speakers also will
Yes,
participate.
ma'am. Yes, ma'am. Would like to
Yeah.
We'll
encourage more.
encourage them.
Yes,
Yeah.
ma'am. Definitely.
Thank you,
Some
Dr.
of you-
Gunadhar, Dr.
Thank you.
Achilles.
Thank you. Thank you,
Yes. Thank you, Dr.
Thank you,
Hitesh.
Dr.
Special thanks to
Hitesh.
Dr. Achilles.
Yeah, thank you, Dr. Hitesh, Dr.
So we
Gunadhar,
have colleagues.
Dr. Akhilesh.
Thank you, Dr. Amit. Thank you, madam. Thank you very much.
Thank
Thank
you.
you.
Thanks.
Thank
Thanks
you,
and
madam.
have a good
Thank
day.
you.
Good night.
Good night.
Good night.
Good night.
Good night.